minimize that. Okay, so welcome everybody. Happy New Year. This is our first 2020 Peds MSK Multisite conference. I have 3 cases to show, but as usual, let's try to spread the wealth around, and if people don't have cases, then we can go through all of them together. But I think Carl probably has a few. So here's my first case. Okay, so this is interesting. This is a 12-year-old male with knee injury, and I'm just giving you a single proton density fat saturated image. And this was done late October of a particular year at an outside hospital. Contrast was not given. It was done sort of as a sports knee, with the regular PDs and the DESs, just to see what is happening. This was basically read out as normal and maybe a little soft tissue injury at this area. But this is a little funny for a soft tissue injury. Hopefully people see that, is that because there's nothing overlying in the subcutaneous tissue. There's no bony contusion. Just this little thing looks somewhat innocuous, but not quite normal. So the patient felt better and was lost to follow-up, and then came back later. Now this same kid in June of next year with something bigger in that area. And again, for whatever reason, at this outside place, and this could be some other outside place, contrast was not given. We see this sort of soft tissue lesion here. This is again a PD fat sat. T1, it was hypo. It was low signal, and steroid was bright. But this is sort of representative of what that lesion looks like, sort of centered in the retinaculum, sort of maybe some in the deep soft tissues, maybe some in the subcutaneous soft tissues. So on June 3rd, again, they said, let's watch it. Maybe it's a vascular anomaly, vascular malformation, but it was behaving a little funny. And finally, we had them come to Children's, and at this point we said, well, this looks really funny. Let's give contrast. Let's see, and we have this T1 fat sat post contrast and a more aggressive looking lesion. So almost a year later, this is biopsied. So anybody have an idea what this may be?
Well, it is enlarging and looks aggressive, like some sort of sarcoma.
Okay. And do you have any guesses about what kind of sarcoma it might be? I mean, I'm asking you to be a pathologist, but 12-year-old.
Like a synovial sarcoma?
Yes, really synovial cell sarcoma. Perfect.
Yeah. One thing we've had as a sort of rapidly growing, solid, somewhat vascularized mass is nodular fasciitis. Certainly mimic a sarcoma in appearance, but I would certainly default to the first item that was given in the differential.
Yeah, no, and Takira, that's great. And it seems like once a year something will come through our department that looks completely benign initially, and then it'll be a synovial cell sarcoma. And so I think the message behind this case, it's not that it was missed or initially, is that when you see something funny, particularly about the extremities, soft tissue, if it's about the joint, you should, and it's a young adult or a young person, that should always be in the back of your mind. Could this be a synovial cell sarcoma? Sometimes I've seen cases in the hands and feet where it looks like purely a tiny cystic something, and then for all practical purposes, it looks like something benign if you saw it in an adult, in an older person. But when they're younger, when they're adolescent, synovial cell sarcoma should always be in the back of your mind. And if there's any doubt, I give contrast and I have a short interval follow-up. So this indeed ended up being synovial cell sarcoma, and the typical age, which this person sort of fit into, was 15 to 40, closer towards the 15 than the 40. The knee is the most frequently encountered region, and typically the soft tissues, it could be in the Hoffus fat pad, it can be the retinaculum, and often, even literature says this, it's a slow growing with quote-unquote benign appearance initially, and that's what this sort of started out with. And just because it's cystic, and don't let that fool you. There are a few parameters. Literature says has a good prognosis, a small size. If it happens in the extremity versus happens in the head and neck area or or near the spine that has a worse prognosis. The younger they are, the better they tend to do. And if it's a solid homogeneous mass versus areas of necrosis or very heterogeneous, is a good prognosis. And if there is calcification, that has a slightly better prognosis than if there are no calcifications. We didn't really have plain films on this kid to look if there were or not. But this is a good case of synovial sarcoma, and again, a reminder that just because it's small and quote unquote initially innocuous looking, that it's not malignant. It could be malignant. Any thoughts from the group?
Yeah, well, I was just going to concur with what you said there, Mash. We've certainly had several cases here over the last few years that the initial study was something relatively small, sub-centimeter, right around the ankle or the knee. Sometimes we've seen a case that mimicked a perimeniscal cyst. We've had a case that looked like a sort of focal synovitis proliferation in the ankle joint. They can be very innocuous on initial imaging, but you're absolutely right. It needs to be in the back of your mind, particularly in a teenager. Neonate, increasing firmness, swelling, discoloration in the hand and wrist. Radiographs showed no bony abnormality. So had an ultrasound at our institution that we're looking at the dorsum of the wrist right now. And so we're coming along this longitudinal view coming down the distal radius. You can see the unossified carpal cartilages here getting into the hand. And the subcutaneous tissues are thickened and a bit heterogeneous. They look sort of indurated. Very difficult to define any discrete planes between subcutaneous fat and underlying musculature or tendons. And you turn on, and this area is one of the things I always want to know from our technologists and from the clinicians too is this soft and squishy or is it firm? And it really did not compress. So turn on power Doppler and this thing really just lights up. Put on some spectral tracings, and I always ask our techs to sample at multiple areas through the lesion, not just turn on color Doppler, but give us several spectral tracings. And so there were a number of low resistance arterial waveforms, also some venous waveforms scattered throughout the lesion. And so this was seen by one of my colleagues, and this individual gave me a call and said, hey, what do you think about this? And, getting some of the history, I have sort of two differentials here. So one is poorly defined superficial soft tissue mass. You always got to think about, cellulitis, trauma, potentially in an older child, maybe granulomedullary, microcystic lymphatic malformation. But one of the things to consider as well is Kaposiform Hemangioendothelioma. And then if you think about, specifically congenital soft tissue masses at the extremity. So I have sort of two broad categories there: fibrous lesions like myofibroma or fibrosarcoma, or various vascular lesions, and when they're more solid, potentially a congenital hemangioma or Kaposiform Hemangioendothelioma. So sort of putting those together, what overlaps, where do we meet in the middle? And thinking about the possibility of a Kaposiform Hemangioendothelioma, one of the questions, the pieces of information that can be quite helpful is what do the coagulation factors look like? This is the lesion that's classically associated with a true consumptive coagulopathy of Kaplan-Meier phenomenon. And so the initial, I'll get to the MRI in a second, I'll just tell you that the initial labs were a little bit off. They weren't crazy abnormal. So the D-dimer was a little up, fibrinogen was a little low. Actually, initially the platelets were normal at 242 and mildly low hematocrit at about 39. So within a couple of days, got an MRI, and these are both fat suppressed T2 weighted sequences. So sagittal on the left and axial on the right. And you can basically see there's just poorly defined infiltrative lesion throughout the hand and wrist. You really can't draw discrete margins around a lesion here. And that's a really very typical appearance for Kaposiform Hemangioendothelioma. And you put that with what happened to the labs in the next day. So over 3 days, not a huge change in the abnormal D-dimer and fibrinogen, but the platelets dropped dramatically over 3 days from normal to 47,000, and the hematocrit dropped as well. And these would be typical of the consumptive coagulopathy that you can see with Kaposiform Hemangioendothelioma. So when all those criteria sort of come together, good age, which most of these present in infancy, poorly defined lesion by imaging, and classic coagulopathy, you don't have to get tissue. In fact, doing biopsy can actually make things worse sometimes. So they will treat presumptively, always with steroids, more recently adding an mTOR inhibitor, rapamycin or sirolimus. And then if it's refractory to that, potentially vincristine. But the patient has actually had a pretty rapid response with steroids and sirolimus, which is what is typically seen. And so is actually doing quite a bit better after initiation of that therapy over the first few days.
Great.
Any comments or questions or thoughts? I feel like for some reason we don't see these quite as frequently as we used to, but it's one of those things I always tell our fellows, you get an infant with a poorly defined soft tissue mass and coagulopathy. This needs to be at the top of your list.
So Carl, I have a question.
Yes.
Let's say we have, somebody in this age group. This was, how old is the kid again? He was just
he was just 3 to 4 weeks old.
3 to 4 weeks old. And then they come in, and then we see this soft tissue mass. It has a lot of vascularity, looks like a lot of arterial form, and then sort of the knee-jerk reaction for many of our trainees will be, oh, this looks like a hemangioma.
Yeah, right.
If you didn't have the lab data, are there other clues from imaging alone that leads you down the path of Kaposiform and hemangioendothelioma and not hemangioma?
Yeah, so one of the dividers, there's a few things I think. So, was it there at birth? So classically, the much more common infantile hemangioma shouldn't be there at birth, but it's going to show up in the first few weeks of life. Typically has a classic cutaneous appearance, but should be lobulated, soft, not firm, should be fairly well defined on ultrasound. You shouldn't see it infiltrating the deeper soft tissues. Like my personal experience is outside of a syndrome associated with infantile hemangiomas like facies, they are always isolated to the subcutaneous tissues. Now that's a little bit different from congenital hemangiomas. So obviously you're born with it. The proliferating phase is usually done by birth. They can actually grow or seem to grow because of intratumoral hemorrhage that can occur. But they can be more ill-defined and infiltrative, can have calcifications. So there is some overlap here. And basically on the ultrasound, the differential was given between a Kaposiform Hemangioendothelioma and a congenital hemangioma considerations. But infantile, you really shouldn't. And this was on ultrasound. It was going basically from the dorsum into the palmar soft tissues, and that really should not happen with the treatment.
Perfect. And I just wanted you to explain that for the sake of our residents. And I think Carl gives wonderful talks on all types of vascular lesions. And I think what you said there is so key. Age of presentation, whether it's there at birth or not, the fact that is it mass-like or not, is it soft or not, does it violate tissue planes? I think those are such key information, and thank you for pointing that out.
Thanks, Mahesh.
So it's a 12-year-old male who presented with pain after jumping on a diving board. And you can see here he's got an expansile lesion in his distal femur with thinning of the cortex and a pathologic fracture. But the interesting thing about this lesion is the matrix. It looks relatively organized matrix. Sort of hard to define the end of the lesion. He went and had an MRI. And because he's got a pathologic fracture, there's lots of edema around, which doesn't really help us. But you can see on the T1s, it's a very well-defined lesion. And again, it's got this very organized matrix with these little swirls within the lesion. You can see post-contrast, sort of diffuse the enhancers with little focal islands of non-enhancing tissue. And what was most interesting then, we did a CT just so we get a better look at this matrix of the lesion. And you see on the CT, again, it's got this very organized pattern with whorls of calcification, very well defined proximally. Got thinning of the cortex, there's no periosteal reaction, there's lots of edema from the fracture. And maybe a little bit of ground glass matrix distally. So, any thoughts from the audience?
I guess it's a pathologic fracture through a benign appearing lesion. At first I was thinking like aneurysmal bone cyst because I thought I saw fluid levels, but on the CT it doesn't really look like that. And I guess like telangiectatic osteosarcoma is kind of off the list also because it doesn't look aggressive. And chondroma is kind of what it looked like on the initial plain film. Anyone else have ideas?
And chondroma,
I think that's all.
That was in our differential.
Right. I think so. When I look at this, and I have no clue what this is, but that pattern of calcification, almost serpiginous, almost arcs and whorls. So that tells me that there's some kind of a chondroid matrix involved, maybe, in this lesion. But that ground glass sort of throws me off a little bit. I mean, could this be a sort of a weird case of fibrous dysplasia? It's localized to the metaphysis. Osteoblastoma is something that I think of sometimes when I see this sort of funny calcification expansile. There are two forms of osteoblastomas. One that looks like osteodastioma. Other one's more mass-like. So, and you've got this sort of scalloping also of the cortex, particularly visible on the axial images. So it looks benign. That's about all I can say.
I think
with your thought of fibrous dysplasia, because fibrous dysplasia can look like anything, and it certainly is expansile. It looks fairly benign.
Yeah, no, very good suggestions, everyone. So this turned out to be a cartilaginous variant of fibrous dysplasia. So you're all right. So I just said, anyway, here's just another sort of companion case. 6-year-old male, pain for 2 weeks. And here you can see, again, there's a sort of a lucency here. It's sort of hard to define it. There's no sclerosis at the margins. And he's got a periosteal reaction. So again, you wonder if he's had a pathologic injury to this lesion. Sort of hard to define the matrix, but again, you're a bit biased, could be a bit ground glass. Had the CT, and it shows that there's the lesion. I sort of windowed this one a bit harsher so you can see the lesion a bit better. So there's a ground glass appearance potentially, and it has some focal areas of calcification. On the MRI, it's again well defined, internal matrix, and it's got enhancement mainly at the periphery with a few central areas of enhancement. Similarly, you can see the changes, periosteal reaction from the pathologic fracture, internal matrix. And this came back for the pathologist, cartilaginous fibrous dysplasia, but it doesn't look exactly the same. And if we look at fibrous dysplasia, you can get cartilaginous islands present up to 10%. But cartilaginous fibrous dysplasia is a variant of fibrous dysplasia where you have extensive cartilaginous differentiation. So I almost wonder if our pathologists haven't seen the first case, saw a bit of cartilage in the next one and call it the same. I don't know, it just doesn't look quite the same radiologically. Maybe there's a bit of calcification here, a bit of a whorl there. So maybe this is a little bit of calcification. I'm not sure what the definition of how much pathologic calcification you have to make the diagnosis.
Yeah, that's a great case, Karen. Thank you.
And I'll just throw in this one for the residents. So this is not to be confused with this condition, which is focal fibrocartilaginous dysplasia, which is basically a cortical-based lesion, which pathologically has collagen and fibrous tissue and cartilage, and etiology unknown. It's sensory self-limiting, but it can lead to deformity over time. So very similar sounding name, almost identical sounding name.
Cartilaginous variant of fibrous dysplasia versus fibrocartilaginous dysplasia.
Yeah, not to be confused.
Thanks.
Okay. Thanks, Mahesh.
Thank you. So, anybody else have cases to show?
I mean, this is great. This is great case. I mean, I never seen this kind of.
Mish, now you're making us
But
feel
on
bad.
the
See, like, not.
first-
I mean, that's Kieran has got enough praise today. Okay.
Yeah. On the first case, the expansion is very, very uniform, endosteal thinning and stuff.
But you know what's interesting?
Usually the fibrous dysplasia does that.
Well, you know what's interesting again, I think going back to sort of fundamentals of what lesions look like, scalloped margins, arcs and whorls, that sort of tells us it's a cartilaginous base, probably cartilaginous base lesion. And the fact that you've got some areas of ground glass says it's fibrous dysplasia, So even if as long as you could sort of put those two together and say, you come up with something reasonable at least, and you could say that it's probably benign, given those parameters and what's doing to the bone and soft tissues around it. So this is a 1-year-old male with a knee mass. So I give you the ultrasound images first. I wouldn't pay too much attention to the calipers here because they're probably not quite. The depth of it is probably underestimated because I can't really tell what the margin is. Little color was placed, but not really hypervascular lesion. Maybe a tiny bit in the periphery, but the mass itself was not very, very vascular. It looks like it's in the subcutaneous tissues. Whether it actually goes into the muscle or not, it's hard to tell from the ultrasound. So we went ahead and did an MR. So here is the image on the left. These are all coronal images, T1 weighted images, T1 fat sat, and T1 fat sat post-contrast. So again, somebody in the residency, could you sort of describe this to me and then tell me what your thoughts are as far as the diagnosis?
It seems like a very well-defined, circumscribed lesion, and it is heterogeneous and T1 weighted imaging and shows and also shows post-contrast enhancement, though the post-contrast enhancement is homogeneous. And it appears to be pushing the, it's sited at the distal, so it's sited medial to the distal femur, but it doesn't appear to be arising from the femur itself. And I can see that the ligaments, sort of the collateral ligaments, it's pushing the collateral ligaments to the side. So it could be arising from the joint capsule. So I think maybe it could be something like a synovial, probably like a synovial mass. Maybe it could, I would think about things like synovial sarcomas. That's, I really can't think of anything else in the differential.
Well, I think what you're seeing in the periphery there, I don't know why I lost my mouse, is the fact that in the very periphery you are seeing just the fascia. I don't think that's actually a collateral ligament. And the key here is the age of the patient. The key is 1 year old, so less than 2, less than 3, and the T1 weighted sequence versus the T1 fat set. Majority of this lesion sats out, so there's fat in this, right? And then if you look at the post-contrast, it does have enhancement. Right, the fact that it's a solid mass doesn't really help you as far as whether it's sarcoma or not, but the fact that it has fat in it, and the fact that it is a young person, less than 2 years of age, 2-3 years of age, a fat-containing lesion is going to be benign. So this is not going to be a synovial cell sarcoma. So this is, as this showed, is a lipoblastoma. And I have this little list that I just took from Pediatric Radiology. The article is listed over here, the reference. But if you look down the line, like a lot of people worry about liposarcoma, but remember liposarcoma is extremely uncommon in the pediatric population, particularly if they're in this age group. And if you look at this age variant, the age life cycle, it's 10 to 15 years of age. So if you look at anything less than 2 years of age, diffuse lipomatosis, lipoma, lipoblastoma, right? Lipomatosis of the nerve, fibrous hematoma of infancy, so these are all young diagnosed and they're all benign. So if you see fat in a soft tissue mass and they're younger than 2 years of age or 3 years of age, you can be pretty sure that it's a benign condition. Any thoughts about that from the group?
That's the, I think that's the Toronto article, is that right? Oscar Navarro?
Yeah.
And,
Yeah.
Yeah. He writes some wonderful soft tissue mass literature in pediatric radiology and radiographics. And, yeah, I just concur with everything you said there, Mahesh.
Perfect.
Mahesh, does
Yeah.
it still require like a full excisional biopsy?
So there's lipoblastoma and there's lipoblastoma-tosis. Lipoblastoma tends to be well defined, and then you can just go ahead and take that out, and very rarely does it recur because it has such nice margins. Lipoblastoma-tosis, even though it's considered a benign entity, because it's so infiltrative that it can come back, but it's not malignant. So in other words, it doesn't have a metastatic potential.
This was a 9-10-year-old who presented with fever of unknown origin. More specifically, was having fevers up to 102, 103 Fahrenheit over several weeks, sort of intermittently, and seemed like every other day by one report. And then started having some bilateral hip pain and was found to have some elevated inflammatory markers. And the initial radiographs of the pelvis were normal, and that led to an MRI. So on the left, we've got a coronal stir, and on the right, we've got a coronal T1. And I think everybody can see that there are multiple lesions here throughout the visualized bones, all of which are fairly homogeneously bright in this stir sequence. So we have one, the intertrochanter right femur coming out to the lesser trochanter, but not seeming to involve the physis. There's no really surrounding soft tissue abnormality, no periosteal abnormality, not well-defined margins on the stir or, importantly, on the T1. Has some other lesions here in the left ischium that comes up to the triradiate cartilage, but the cartilage itself looks okay, and the other side, the cartilage in the ilium, looks okay. We've got left iliac bone involved here with a similar lesion, again, kind of poorly defined margins, both on the stir and T1, and then some definite sacral ala involvement as well. And again, at each of these levels, there's really no appreciable joint fluid nearby. There's no significant soft tissue abnormality. Nothing seems to be disrupting the cortex. No real periosteal reaction. So, any considerations before I discuss this any further?
So I think our residents are going to nail this one.
Yeah, I thought I was going to nail this one too.
Residents, do you have any thoughts about this? What did you say? I'm sorry?
CRMO.
CRMO. Right. So that was my initial thought, Carl. Was when you're showing this, I thought this was chroma.
That was exactly my initial thought too.
Oh.
Got multiple lesions. I really harped on the fact that the margins are kind of poorly defined, right?
Yeah.
Because as I think Kieran pointed out in one of his cases, when you see really sharply circumscribed margins between the fat and the lesion on T1, then you're definitely thinking about some sort of tumor or neoplastic process, be it benign or malignant.
Right.
But when you get more ill-defined margins, you're thinking, is this infectious, inflammatory, post-traumatic, something like that. And so, given that you've got multiple lesions scattered around the pelvis and the proximal femurs, and some of them kind of come up to growth plates, and they're in sort of a distribution that can often be seen with chronic recurrent multifocal osteomyelitis, that was definitely the first thing that came out of my mouth. Now, what I would like to have seen that maybe would have made the case a little stronger was if I really like it when there's sort of symmetry across a physis. Like sometimes you'll see equal parts, like greater trochanter and directly adjacent metaphysis involved, or on either side of the triradiate cartilage. Sometimes they'll be relatively symmetric from side to side, like, right, left. And we didn't really have either of those things here. Nevertheless, I really thought that that's what it was going to be. I didn't really think it's a good look for pyogenic osteomyelitis because there's no soft tissue abnormality. It's so multifocal, and the kid was otherwise pretty well despite having these fevers. So the rheumatologist came down to discuss the case and said, kids with chronic recurrent multifocal osteomyelitis don't typically have high fevers like this.
That's true.
And I was like, okay, so sort of take a step back. And one of the questions that the rheumatologist asked was, is there any chance that this could be cat scratch disease? And I said, I really don't think so. There's no adenopathy. The majority of cases that I've ever seen of cat scratch disease, certainly you can have bony involvement, but every case I've seen had adenopathy somewhere, and that's the classic and primary presentation is usually adenopathy a few weeks after exposure to a kitten. And this rheumatologist particularly brought this up because I guess in the last year we'd seen a case of osseous involvement by Bartonella henselae that was initially thought to be CRMO and turned out by biopsy and titers to be cat scratch disease. So because the history didn't really make sense and they were sort of doing it first for CRMO, they did sort of an extensive workup, and that included cat scratch titers, and they also biopsied one of these lesions at H1. But it all came back consistent with cat scratch disease. The cat scratch titers were through the roof, in fact, with the IgG, and the patient about 3 months prior had exposure to a kitten. So, the few cases I'm aware of bony involvement have been either vertebral or isolated single-site bone lesion. They can get systemic involvement. You can get hepatic and splenic involvement. You can get CNS involvement with encephalopathy. You can get pulmonary involvement. But I'd never seen multifocal involvement in this particular entity.
That's crazy.
Treated appropriately and has actually done quite well.
I might just go back and put addendums on all my CRMO.
This would make a great mimic. My God.
Of my fine colleagues who would have said the same thing I said.
Wow, I would have bet a lot of money that this was going to be trauma. All right, great. Thank you. That was awesome.
So it's that 15-year-old female with the right buttock lump, and here's the ultrasound. The X-ray didn't really help. You couldn't see it on the X-ray. And here's the ultrasound. So you can see it's deep to the gluteal muscles, and it's sort of sculpting the underlying iliac bone. And again, it has little arcs and whorls. And on the Doppler ultrasound, there's a little bit of flow just to the periphery. And so this is just a cute case, but I guess what was impressive about this was on the ultrasound, they said this looks like a chondroma.
So Kieran, can I make a comment real quick?
Yes.
I would say, so forgive anybody who's offended. What kind of half-assed diagnosis is that?
Well, let me give you the differential. But that was number one on the differential.
I'll play it, Mahesh.
Well played. Right?
Don't encourage him, Carl. Don't encourage him.
And anyway, and here's the MRI, and you can see again, it's sort of scalloping the underlying iliac bone. It's a well-defined lesion with, can't really see the arc, but they'll better see it on ultrasound, and it's a peripheral enhancement. And I really just showed this case to Mahesh, say that joke. But it turned out to be a juxtacortical chondroma, which I thought was a pretty good diagnosis on the ultrasound.
Yeah.
And I just got one very quick case. It's more a revision case because I've shown it before. Those cases that come through and you've seen it before and then you don't get it and it's really annoying. This is one of those. I thought if it's good revision for me, it's good revision for everyone. So this 11-year-old male with left hip pain, While I didn't get the case, I did get the next test and said do an MRI, so that was fine because came in a wheelchair, and I thought that's not good for an 11-year-old. Any comments from the crowd? Show you the frog leg view as well.
Does that left neck intertrochanteric region look a little dense and irregular?
Well, he does have maybe a little bit of change in density there, and there are lots of soft tissue changes there, so that might explain the density. And it is a little bit hard on these images.
Yeah, what about that obturator fat pad on the left side?
Yeah, good work, Carl. Yeah. Obturator fat pad is thickened on that side. Particularly on this view compared to the other side. And there's the MRI.
Nice.
So basically, it's an osteomyelitis with an obturator internus abscess. Just going back to the residents, I mean, everyone knows about the psoas fat pad. You see thickening of the psoas, but here's the obturator internus. And what was particularly disappointing for me for this case is I'd actually shown one of these at this meeting before. But at least I recommended the MRI, so no harm done. But yeah, it's nice if you can pick it on the radiographs.
That's a great point, guys, because sometimes, we're taught to look at joint effusion and look at the plain films. There really isn't, there's joint effusion on MR, but there's no sort of displacement of the femoral head from the acetabulum. So it looks like there's no asymmetry in the joint space. In fact, there's less joint space on the left.
Yeah, so the other side. And I find that soft tissue is really hard to interpret, and that's probably the only reliable one I find.
Yeah.
And then if you look at the X-ray, you can see why it's not displaced because all the fluids on the femoral neck. And here's basically the MRI equivalent of the fat pad. Sometimes the fat pad is displaced by the thickened obturator internus. So anyway, hopefully I will get this next time.
That's a great case. So this is another good one for our trainees. So here is a 12-year-old male with a chest lump. So we see sort of a moth-eaten appearance to the lateral aspect of the clavicle with what looks like Codman's triangle, very irregular margins. There's probably a big soft tissue component that we see over here. I don't know how well that's going to project, but there it is. And here's the Codman's triangle on either side. The margins here are very ill-defined. You don't know where the mass ends and the cortex begins because there really is no cortex whatsoever. And then we got an MR. So this is a coronal T1 fat-sat post-contrast. It's sort of a zoomed-up single-slice view, but this is that area of the lesion. Here's the big soft tissue component that we showed. Very abnormal. So for our residents, what do you think the diagnosis here is?
Something aggressive like Ewing.
Okay, good. I like that. Was that you on? Or?
No, it's Cody.
Oh, hey, Cody. Good job, Cody. Now, I'm going to show you another case. So, clavicular lesion, except here it's more the medial aspect of the mid aspect. There is some periosteal reaction. I think it looks a little bit more mature. There's more sclerosis and lucency sort of intermixed. I can't really see a big soft tissue component. Very superficially it sort of looks like the other lesion. What do you think the diagnosis here is?
Bartonella.
The osteosarcoma?
Okay, somebody says osteosarcoma. Unusual in the clavicle.
I agree with Kieran.
Cody, what do you think? Since you nailed the first part of this case.
Still concerning because of the periosteal reaction. Not a typical place for infection.
Okay, so you heard your other attendings sort of give you a clue. I'm sorry?
Any history that'd be useful.
Well, the history is, it's painful. The skin is a little red overlying it. Has history of joint problems before, but nothing too
Maybe.
major.
Yeah, maybe like a chronic osteomyelitis picture, but again, kind of a weird for infection to seed.
Yeah. So this is the MR. So again, just to show you that it's a crappy MR. I'm sorry. I'm just the one slice, but this is the clavicle you're looking at. This is the lesion that's involved, and there really isn't a big soft tissue component like we saw in Ewing sarcoma. So this is a case of chronic recurrent multifocal osteomyelitis, and I put both those cases up here for your viewing pleasure, and it's a good way to show the contrasting elements for each one. So this osteosarcoma, oftentimes there's no sclerosis, a large amount of sclerosis. Often the bone isn't hyperexpanded as it is in chromo cases. Typically, Ewing's tends to like the very lateral aspect or distal aspect of the clavicle as opposed to chromo, which typically affects the mid to more medial aspects. Again, if there is really no soft tissue proliferation on the chromo, you may have some periosteal reaction, and often that tends to be mature, typically if it's a little bit older. And as opposed to the Ewings, where the periosteal reaction is very aggressive looking. There's a Codman's triangle. So if you see a clavicular lesion like this, and there's a history of maybe low-grade fever, maybe mild elevation of inflammatory markers, those criteria alone is enough to diagnose chromo. So you wouldn't necessarily need a biopsy. So this is one of the classic lesions for a chromo. But I just want to contrast this with Ewing sarcoma, so you have a mental image in your mind to hang your hats on of what chromo looks like versus what Ewing sarcoma looks like. Or maybe this is a cat scratch. I have to go look at that. Any comments from the rest of the gang here?
I've got a case I'll show next time, Mahesh.
Okay.
But can you get Codman's triangle? And I think you can with other. It doesn't really mean it's necessarily a tumor. It just means it's rapidly growing. I've got an aneurysm bone cyst in the lateral.
Yeah, no, it just I could see infection can give you Codman's triangle. It just means that it's an aggressive lesion. Hey, thanks everybody for participating. This was a great turnout. Lots of people and great cases. Thanks everybody for showing up. Kieran, especially for coming in at 6 o'clock in the morning your time.